I had the pleasure of meeting yesterday already from Toronto. How are you today? Your microphone is still mute.
Okay, how is the weather?
Oh, it's snowing. It's snowing. As I promised you, it's snowing.
Yeah, we have a nice sunny day today here.
Wonderful, wonderful.
Nice.
Okay, let me introduce you, please. Dr. Farook is basically a surgeon specialist with qualification and experience in healthcare quality, risk management, and patient safety. The key area of your experience includes training of healthcare providers in a wide range of patient safety initiatives, leading multidisciplinary teams for FMEA and RCA, and facilitating transforming of organizational culture. And therefore, this is a speech that you have prepared for today, your keynote speech, establishing an organizational culture for patient safety. Please, Dr. Farook, the stage is yours, please.
Thank you, Suzanne, for your wonderful introduction, and it's a pleasure. I thank the organizing committee to have organized such a fantastic conference, and I was with them last year also, and the conference went exceedingly well. And they have been communicating very regularly, very effectively, very efficiently from time to time to see that we need some help, some support. Please communicate to them my thanks and regards. And I think I should get started with my presentation. I'll be speaking today. Yeah, this is one of the key areas of my expertise is culture. And the culture is at the heart of what's happening. Okay, all right. A culture, especially a safety culture, is at the heart of organizational efforts to improve patient safety. Not only patient safety, it's the staff safety and engagement of staff and outcome of patients in terms of their well-being. Getting into the hospital with an ailment and leaving the hospital well satisfied with wonderful outcomes in terms of their return to normal work. I don't have anything to disclose, and I don't have any financial interest or commercial interest in any of the slides which has information which will be presented today. So that goes about the disclosure. And now the journey of my presentation will go towards discussing the definitions of culture, corporate culture, and also basically eventually we'll be going to safety culture. And I will explain why we need to establish patient safety culture as a key function in an organization, and what's the role at various levels, starting with leadership, middle managers, and the frontline staff. And then I will just quickly go through a couple of video presentations about safety culture and just culture. And I will also explain the tools which are used to promote a safety culture. And then, of course, there are always roadblocks in whatever we do, whether we do a change management or we try to change the culture, or we launch a quality improvement project. There's always a roadblock, and I will just try to highlight some of the strategies which we can use to overcome the roadblocks. And then also I will quickly take the audience through assessment of safety culture maturity. How do we progress from a pathological culture to a learning culture? Because there's still organizations around there which still perhaps are in either in a pathological culture or a generative culture, and things, if they have to achieve total quality management, continuous improvement, they need to build up efforts to go to a safety culture. And then I would appreciate any questions towards the end of the presentation. Basically, science of patient safety has been around since about last 2 decades. And we all agree that we make errors. Errors are happening in many hospitals, many clinics, even now at this moment of time in 21st century, and we are all vulnerable to making errors. And we should always try to focus our efforts on the system and try to improve the system rather than looking at the perhaps bad apples or bad oranges. The traditional approach was that whosoever made a mistake would say that this doctor, this nurse, this pharmacist doesn't know how to handle patients, doesn't know how to handle their jobs. But we don't go into the details. How have we oriented them? How have we taught them? How are we going to improve them? How are we going to educate them? So it's basically the systems which are broken. Not every healthcare provider who comes to the hospital on a daily basis has no intention of harming a patient. They never come with that intention. But it's a system. Except one thing is the reckless behavior. Certain healthcare providers do definitely, even today, have some reckless behavior, which is, of course, reprimandable, but eventually mistakes happen because of poor system, bad systems. And at the heart of this safety culture is your ability to speak up. When you see a thing, speak up, whether it's a consultant doing something or a specialist doing something. Even if you are a medical student, if you see something is not going well, you have the right to speak. And eventually you will be appreciated for that. And you have to bring up your concern. And people have to accept responsibility for the errors. If we made an error, we should admit it, we should report it. And that's how the chain of improvement gets initiated. If we don't report errors, they don't get to the discussion, they don't get to the committee, they don't get to the team, we don't discuss them, we don't know the causal factors or the root cause. And that's why one of the fundamentals of patient culture, one of the fundamentals of improvement is reporting safety events. That is the root cause. Unless we report, we can never improve. We have to identify and report them. And then, of course, this is a concept in psychological safety is critical language. There are certain issues which have to be used while, especially when you are working in high-risk areas like ICU and like neonatal intensive unit or operation theater, where normal language sometimes may not work. You have to be critical. You have to be forceful to stop the line. You need to stop the line now, otherwise the patient will have a asphyxiated baby, or otherwise patient will die of hemorrhage, or anything can go wrong and we'll lose a patient. So this is very important as well. Now, what values do we hold? What are our beliefs? How do we act? This is basically all about culture. And you can see how we go through this culture. These are the three basic fundamentals of a culture. And I think most of the audience which is listening to this presentation, they know that culture eats strategy at breakfast, also at lunch. But a time will come, they will put it for the dinner also. Because even if you have the best strategy in the world, even if you have the best tools written in your policies, procedures, or manuals, or whatever, if you don't have a culture, a safety culture, or a just culture, or a learning culture, your strategies are bound to fail. They won't be implemented. And also the same thing happens. They will be eaten at lunch. So culture is very important. If you have to change something in an organization, work on your culture, the strategies will be implemented. Another way of explaining what is culture, the way we do things around here, one person's attitude is an opinion. Everybody's attitude is a culture. So it's a collective effort. When we fail, when a patient dies, we do a root cause analysis. We never find a single individual responsible for the error. We find a collective failure of a system. And we definitely we interview doctors, we interview nurses, we interview pharmacists, and eventually we find out where the defect was, who was responsible, And we don't have to reprimand our healthcare providers. We have to talk to them, we have to educate them, we have to support them. Because at the end of the day, they are defined as they also are feeling the load. They are as of an adverse event. And sometimes, I don't want to go to the details of those things, healthcare providers go to extreme steps because of regret and remorse if they hurt a patient. Never there's an intention to hurt a patient, never. And now we have the hardware and the software in an organization. Because organizations I think are like computers. We have organizational structure, we have policies, we have rewards, system of rewards, and we have compensation and sanctions. And also, unless this hardware work is complemented with software, effective software in terms of values, beliefs, and our behaviors and attitudes, meaning culture, the hardware will not work unless we have a functioning software in an organization. Next, we come to safety culture. Safety culture is the same thing, actually. Values, attitudes, perceptions, competencies are very important, and patterns of behavior are very important. Behavior determines whether our efforts will be successful or not. Because one of the reasons why healthcare, why we couldn't improve organization is something called as authority gradient. It works at work. Authority gradient has been one of the major failures why organizations were slow to implement safety culture, because there's always a scare. She is a director of nursing, she's a nursing supervisor, she's a staff nurse, she's a nursing assistant. How can a nursing assistant bring an attention of a supervisor or a charge nurse? They're scared. So that has to be dismantled at all levels. It has to be dismantled. I have seen in organizations, authority gradient is a roadblock to developing, establishing, and promoting safety culture. Very, very important point to be taken. And leadership, it has to be a leadership top priority. Leaders determine the culture. Leaders establish the priorities. And of course, leaders do it in consultation with the middle managers and the front line. And we should see culture in their symbolic behavior. They have to behave. Leaders have to behave in such a way so that the middle managers and the frontline staff, they basically copy them because they are role models. Let me show this video, which I have shown at many presentations earlier on. It's about safety culture. What's a safety culture? I think it's a video, maybe a couple of minutes, 2.5 minutes. Do I have the permission to open it? Suzanne? Thank you.
It has to be a just culture, not a blame-free culture or a punitive culture, but a culture that has negotiated where to draw the line between unacceptable unsafe acts and acceptable unsafe acts, or honest errors.
We just see that, we just hear it, we don't see it.
Oh, okay, okay. One moment, please.
To tell you about their near misses, about their free lessons, then you begin to have a reporting culture, a culture which enables you to learn the details of the edge between hazard and safety.
Can you see it now?
And once you have a reporting culture, you start to have a memory.
Yes, we can see it.
Has a memory, and it can begin to learn and change and improve its defenses and its safeguards and its barriers. But it also has to be a flexible organization. It also has to change its configurations according to the tempo of the work. All of these things are essential parts of a safe culture.
Any organization can do a simple cultural health check by answering 6 key questions. Do we really understand what error is? A failure of the system, not just individuals. Are we honest? Do we condone shortcuts to save time, money, or effort? Are we informed? Do we really know what's going on? Are we learning? Is there feedback to realign the system? Have we forgotten to be afraid? Is there respect for the hazards we must manage day by day? Do we ask ourselves this kind of question often enough? Are we proactive? Do we have ways of removing the causes of error before harm can occur?
Every person who works in healthcare comes to work every day intending to do good. They're there for the right reasons. And they feel really devastated when things go wrong. So part of our work needs to support them. We're also conscious that when we're more transparent about patient safety, that the public may lose faith in us as a caring, safe organization. And so there's a lot of education we need to do there for the public as well. But I really believe that as part of our accountability to the public, we need to be honest. We need to tell them when things are not the way they should be and what we're doing to improve.
Hello?
Yeah.
Yeah, is it okay?
Yes, absolutely. Are you going back to your presentation?
Yeah, I'll go back to my presentation, yeah.
You okay, or shall we screen the presentation for you?
Yeah, I'm going to screen the presentation. Yeah, here we go. Okay, are we okay?
Yeah.
Okay.
Back on.
Now, let's discuss. There are certain similarities between organization and the forest. Is it clear? Was the video audible?
Yes, absolutely.
Okay.
Just put your presentation on presentation mode, please. That would be great.
Okay, fine.
All these requests.
All right. And now
Perfect. Thank you.
the ecology of an organization is as delicate as well as vulnerable as that of a forest. Every organization has an ecology because nothing happens without influencing something. So as we discussed, as we saw in the video, the behaviors manifest the way we deal with healthcare providers and the way healthcare providers deal with their patients. A relationship forms one of the basics, one of the fabrics of improvement. These have to be the key to all things within an organization, as with the forest is relationship, because relationships determine a lot. And once the relationship within the organization is good, is proactive, is cooperative, then we can see good teamwork. And once we see the good teamwork, the culture will be easy to establish and patient outcomes will definitely be improved. And these failures are still happening. Statistics are still in favor that the leading cause of all our sentinel events or adverse events is still the communication failures in 60 to 70% of cases. And as I said initially in my presentation, pathological safety is one of the hallmarks of safety culture. And what is psychological safety? Psychological safety. Psychological safety is an ability of a healthcare provider to raise a concern. They should be free to raise a concern. Even a medical student should be free to raise a concern to a specialist or a consultant that I am seeing something wrong and we have to do something about it. That's psychological safety. And authority gradient, I've already discussed before, it has to be dismantled if we really need to achieve patient safety. Now you can see this. This is a very tragic situation which happened in Cardiff. A normal kidney was removed from a patient instead of a diseased kidney. And there was a medical student who was observing the surgery. A medical student raised a concern that we are removing a healthy kidney. And the surgeon disregarded his comment, his concern, and they went ahead with the surgery. And the surgeon and the urologist made a disastrous mistake. It was a disastrous mistake. And this, may God have peace on his soul, this patient, he was a veteran, Korean War veteran. He lost his life after about a few weeks after the surgery, because he was a normal kidney was removed, diseased kidney was kept. So that's why I'm saying, speak up, psychological safety, authority gradient, and critical language. If an attention was provided to medical student, this patient would not have died. This is one of the examples of this thing. So I want to get this point very, very clear to all the healthcare providers that we should listen to the concerns of every staff when they are raised. Speak up or keep quiet is the option. I would always go with the green one. Speak up when you see something going wrong. Speak up. And always speak up for patient safety. One of the basic fundamentals of patient safety culture. When you see something wrong going, especially in areas of critical care, neonatology, ICU, OT, or whatever, speak up. Don't keep quiet. Always express yourself that I'm concerned. Discuss. I am uncomfortable in this situation. Something is happening. I'm not comfortable. And this is a safety line. This is a safety issue. Stop the line. Once people speak while the surgery is going on or a baby is being delivered, I have done a lot of root cause analysis on asphyxiated babies or neonatal deaths. When I have seen that there was a delay, a junior doctor was struggling to deliver the patient. A junior doctor was frustrated and she applied forceps, rushed through this thing, and they gave up asphyxiated baby to parents. They didn't call the seniors. Nurses were looking at it. They expressed regret that because of authority gradient, they could not speak. They were scared to speak. So many babies born asphyxiated or they died. So please, this is very important. And how does the evolution of safety culture go from bottom, from the front line up to the leadership level? Report your near misses. Very important. Near misses are free. They are free lessons. If there's a near miss, report it. Don't hide it. You will learn something from it. Get it analyzed. Make a team. Let them look at it. And you can correct a system. You can correct a policy. You can correct a procedure. You can correct a protocol. And also it leads to a proactive assessment of our systems. Because if we don't report, nothing is going to improve. And we are going to harm the patients again and again and again. How do we improve safety culture? These are some of the strategies. First of all, we have to improve our measurements and evaluation process. That's very important. Where do we stand? That's the bottom line. Then we have to establish our educational training programs. I used to run a training program in Dubai Health Authority myself, and we used to have a quality and patient safety program in one of the hospitals, Latifa Hospital in Dubai. I ran it for about 3 years. And it led to a lot of improvement in patient safety awareness, actually. And slowly, and they're still continuing to do it. And then improve the communication processes. And also improving communication needs continuous reminders, continuous training, especially critical language, very important. Speaking up, very important. And then you have to improve your legal and regulatory processes. Basically, let us start from number one, journey to patient safety culture. How do we change our culture? First of all, we have to evaluate it. Where our culture stands. There's a way to establish patient safety culture has to be evaluated there. We have to ask the staff, surveys have to be done, they have to be logged, they have to be cataloged, and we have to understand, then we have to have an interpretation. Eventually, we need to come up with some recommendations. And we have to encourage patient safety learning at all stages in the organization, at all levels. And we have to identify staff concerns. And we should be telling our staff every now and then, if you have a concern, bring it up. That's the way you are going to contribute to patient safety. If you don't come up with your concern, our safety will never improve. And then you can see these patient safety leadership walkarounds. Actually, last year I presented patient safety leadership walkarounds. This is one of the best tools, I think, available out there through which you can improve the culture of safety in an organization. Leadership walkarounds, leaders go and walk in the wards, they go to OT, they go to outpatient department, they talk, they invite questions, and those questions are analyzed, assessed, and action plans are developed. We used to do it every month in Dubai Health Authority. Then based on what the staff says, we have to prioritize improvement opportunities, launch quality projects. But everything comes from bottom up. The information is there. There's a lot of problem there. When you open the cracks, you will see a lot of problems. Unless you open those cracks, you won't be able to know what's going on in the front line. You have to encourage them to speak. They are the best teachers for you. So they will tell you what's going on. How are we harming the patients? What do we need to improve communications? How would the next patient be harmed? They will tell you. And then implement improvements, share stories, and disseminate results. Every month, the CEO should call a patient's staff meeting where we should share the results of incident reporting, results of the near misses reported, actions taken, and quality improvement initiatives initiated to improve those gaps in patient safety. Then, of course, again, the cycle goes again. We reevaluate patient safety culture every 2 years or 3 years and see how to improve it. And this cycle is very important if we have to go from the base till the end, and again, keep on improving our safety culture. Now, this is an interesting slide. I was talking to you about certain organizations are still in pathological culture. They say, why waste time on patient safety? We've been doing patient safety since last 50 years. What are we going to change? It's a waste of time. Then people realize gradually, then when a lot of patients get hurt or harmed, we need to do something about it. If we have an incident, something has to be done. They started realizing it. And then this is reactive culture. Again, not a good scenario. At least they are doing something. And a lot of organizations are here in many places still. Then is the bureaucratic. Bureaucratic culture is we need to have systems in place to report, manage, and identify risks. Now better, one step ahead of it. Then proactive culture. We would all like to be in this culture, proactive culture. We are always on alert for incidents and risks that might emerge. This is a concept of high reliability organizations. They are always preoccupied with failure. If we are preoccupied with failure, our efficiency will improve, our results will improve, our outcomes will improve. So we have to always report. And the last is generative culture, the last step. We mitigate risks. Risk management is an integral part of everything what we do. Everything carries a risk. And if we identify these risks proactively through FEMA, root cause analysis versus FEMA. FEMA is a proactive tool where we identify risks before they happen. A root cause analysis is a reactive thing whereby we understand what went wrong and how to correct it. So these levels of maturity are very important. Organizations gradually, if they work hard, leaders are really interested, they lead well, eventually they can go from pathological to generative cultures. And now look at the difference, how pathological, bureaucratic, and generative cultures process their information. Pathological ones are power-oriented, low cooperation. Messenger is always short. The one who reports that bad, why did you report it? There was no need. You are embarrassing your colleagues. Responsibility is always shift, and then they are discouraged to report things. And they're always looking for scapegoats. Then we go to bureaucratic. At least they do something better. They have an orientation system. There's some cooperation. Messengers are neglected, but still not short. Responsibilities are still blurred. Failure is tolerated to some extent. And generative cultures are performance-oriented, high cooperation. Messengers are trained. Never shoot the messenger, train them. Because maybe they were never oriented. Maybe they don't know about things. And risks are shared, and the failures are always required. And next we go, I think time may not allow me to go over this video because it's a long video. I'll skip it over. I'll skip it. If we have time, I will share it later. This is a 10-step approach to improve patient safety culture, but it's a little bit time consuming. So with your permission, I can skip it. Suzanne, if we have time, we can go over it. Thank you. Thank you so much.
Absolutely.
Now you can look at it, if you break this patient safety culture journey or structure or function or operation, look at how many things are involved in it. Teamwork, break it into a fishbone and look how important everything is. It all collects together. Evidence-based interventions, evidence-based protocols, evidence-based policies. Leadership is at the top. Leadership at the top. If leadership is not on board, patient safety culture will never be. It's a dream to achieve it, because leaders provide the resources. Leaders provide the motivation. Leaders provide the reward recognition. Okay, so this is very important. Leadership is very important. Something is hiding here. I don't know. Then communication is here. Oh, sorry. Communication is here, and then I think I don't know what's, and patient-centered care is there, communication is there, and all those things. You can see it's in the presentation which I have sent, which the audience can actually go through whenever they have time. We did it in Dubai Health Authority. It took about a couple of months for us to design this, how to develop a patient safety culture. And all these elements are very important. Governance, resources, at-risk behaviors, non-punitive way of dealing things, but non-punitive doesn't mean it should be a blame-free culture. Reckless behaviors have to be reprimanded always. I'll come to that later part of my presentation. I think these were the traditional ways when leaders used to have a clan culture. They used to have their own way of doing things, hierarchy culture. I'm just giving you a historical aspect of what used to happen in the past. But now they used to focus on these traits in their staff. But I think over the years, things have started changing. And I think I won't go much into details of this slide. I'll skip it over. Now, this is a very interesting one. I'll spend some time here. AIM is not blame-free culture. We have to still hold people responsible for their actions. If they did something which was because of their bad behavior, the only way, bad behavior, reckless behavior. They didn't follow a particular protocol, or when they were asked to stop the line, they still went ahead. So high reliability organizations separate blameless errors from blameworthy ones. There will be always some error. This is very important. Blameless errors from blameworthy ones. Blameworthy ones are because of reckless behavior. So that there has to be a boundary. And there is a boundary. If we do a root cause analysis, you'll get to the boundary. You'll get to the cause. And we have to hold everybody accountable. We may not sanction them. We may not fire them, but we have to actually take some action to stop reckless behavior happening in the organization. Safety culture has to be from boardroom to bedside. It has to be from things discussed in the boardroom, eventually go to the bedside, and while frontline staff are dealing with the patients. So obviously when leadership is on board, middle manager should be there, frontline will always automatically come on board. And I told you, patient safety leadership walk-around is one of the best tools for promoting safety culture. You can have a look into it. There's a lot of literature about it. This, if you want to really establish this safety culture, this is going to be very, very helpful. Role of leadership, they provide you they keep you preoccupied with organizational workforce. They give you resources. They tell you this is important. They continuously meet you every month. They re-emphasize the role. Leadership role is very, very important in developing patient safety culture. And again, we come back to the same thing. We should have no blame, non-punitive response to errors. And then, but there should be zero tolerance to one thing, that is conscious disregard of clear risk to patient safety. That is the key. That is where you divide blameless cultures versus blame-free cultures. The errors, conscious disregard. You are told that this patient is still not prepared. You're told that this is a high-risk patient. You're told that some patient is bleeding while we are doing a surgery. Put a pack, stop it, call a senior. You still struggle with your forceps, struggle with this thing, struggle with your hands, and you injure an artery, you injure a vein, and that patient, hemorrhage, blood everywhere, and patient, anesthetist draws your attention. Patient is bleeding, stop. Ask some help, get somebody to look into it. Take a break. You still continue struggling here and there, and you cause the patient's death. Those things are not to be accepted. We have to be fair, but we have to be open. Staff have to report incidents and support caregivers if they are getting involved in it, because they are called as, what do they call it? They are, it's not coming to my mind now. Staff should be free to talk about incidents anywhere, and staff should be treated fairly well when an incident happens, and they should be given off time from work so that they recover, because they also get injured. They are also injured because of an incident. Indirect injury also happens to them psychologically. Engineering of safety culture is that we have to disseminate cultural attributes. It has to be in the roots of our values, and then we have to actually have need to appeal to every individual without threatening an individual's identity. We have to support them if something happens wrong. If the staff know that we won't support them if something goes wrong, they will be hesitant to take high-risk patients, high-risk surgeries. So we have to encourage them to deal with that high-risk patients, high-risk deliveries, high-risk operations, and of course follow protocols, procedures, policies. Call somebody senior if you are in help, but they have to be encouraged. If something goes wrong, you are following a policy or following a procedure, we will be on board with you, we will protect you. And the role of champions in disseminating the patient safety culture is very important. We used to also have this in DHA, We designated safety champions in every department, every clinical department, and also administrative departments, because they are a liaison. The safety champions are a liaison between the departments and the quality improvement and the quality council, because they are represented on the quality council. They bridge the gaps between, they bring the concerns of frontline staff to the quality council for discussion. Ownership of safety culture has to be at all levels. Everybody responsible. The board, the leadership, middle managers, and the frontline. Everybody's responsibility is to keep patient safety, is to adhere to patient safety. It's not only managers' responsibility, everyone's responsibility. It's even the responsibility of the patients, of the relatives attending the patient. We have to educate them also. And a time will come and they will be also given an option to report an incident. It's coming, time is coming. And some organizations are already giving patients the chance to report incidents. So things have to change. Engagement, execution, evolution, this is a process which we have to follow. And it all goes like that. Unless we engage and execute and evaluate, things won't change. And then if we have an organization where we think the culture is not good, we have to acknowledge it, that we have gaps, we have problems. That's why we do patient safety culture. We have to assess the culture and then we have to implement. And the best thing is to have, every organization should have a quality and patient safety program. And presentations should be done by the CEO. We had a CEO in our hospital. She used to present every 2 months a topic on patient safety. Then gradually all heads of departments started. Even admin department used to come. Even maintenance, engineering department used to come and present something about risk assessment of their systems. Everybody has to engage in the safety program. That's how we can disseminate patient safety. These are the approaches to promote patient safety, promote the messages by mission values, by goals, and then by rewarding people, listening and responding. Listen to them if they come to you. And a junior nurse may come to the nursing supervisor and tell her, today I harmed a patient. Listen to them. They will tell you why it happened, where it happened, how I could have done better. Then develop on that story and support them. And next time that same scenario may not happen. But if we shut them down, they'll be depressed and they can harm more patients. Model the behaviors, provide training, and then negotiate to reach agreements on contention and reward. We used to reward the people who used to report maximum incidents. It's not a question of numbers. We were not fooled by the numbers. We were fooled by the quality of reporting, especially near misses. And we used to recognize and reward departments, units, which would report their near misses, close calls, which would develop action plans. There used to be a competition for reporting near misses, and they used to be handsomely rewarded on general staff meetings. So that shows the support the CEO used to give to the whole organization. And then tools are same, leadership commitment at all levels. Incident reporting is the key. Leadership walkarounds, safety briefings and debriefings have to be done. And hurdles is very important. Hurdles is a tool which you can use to promote patient safety culture. Very important. Every day in the morning, 5 minutes hurdles. 5 minutes if staff come together in a corner in a ward or in a corridor or wherever they are. 5 minutes today, what we have, what challenges we have, who is the high risk patient, how are we going to do it, how are we going to deal with it together as a team. It will help a lot. And S-bar and all those things. I added this S-bar, and 2 things to this S-bar. Identify yourself always and allow the other person to ask questions. Situation, background, assessment, and And recommendation, I'm sorry, but always ask the other person to ask questions. What we miss in S-bar is introducing ourselves and asking questions. Give them a chance to ask questions. Hurdles is very important. A reward and recognition system is very, very important as well. And what are the roadblocks to transformation? Numbers are not right. These incidents are not right. We are good enough now. At the moment, we are dealing with patients okay. Not many patients are getting harmed. Patients are, we will never be good enough. These are all, you know, myths. Some people, there are always some bad apples in organizations. Old school, they'll always tell you, this is not my job. Why should I own it? I'm not getting anything more for this. But if you reward them, recognize them, they will come on board. They are laggards, you know. They slowly will come on board. Slowly. And lack of commitment, lack of communication. And some of them genuinely complain because we are not being trained. We're not being trained, so train them. A practical approach for everyone, a good example, unsafe acts are like mosquitoes. You can try to swat them at a time, but there will be always others who come and take their place. The only effective remedy is to drain the swamp in which they breed. It's very, very important. Drain the swamp. This is this is a very important tool. This is brought from politics to healthcare. And the best example of safety culture you can get from aviation. Aviation safety is very, very important. We are not still there as effective as aviation safety, but healthcare organizations are slowly catching up, especially if leadership is going to do a great job. And I think I already discussed this thing on behaviors undermine culture of safety. Behaviors are very, very important. We used to have some senior consultants in some organizations whose behavior was terrible for patient safety. They used to discourage their junior staff to report incidents, and then slowly we identified them and we called them. Confidentially, we called them and we talked to them. The CEO talked to them directly in my presence. They were explained that they have to stop such behaviors. And I tell you honestly, we have issued warning letters to very, very senior consultants, heads of departments, for intimidating behaviors, for reckless behaviors. And slowly, some of them came on board. Some of them left the organization, but most of them came on board. They realized what they are doing is not right, because their behavior was not changed over the years. Their behavior was same over the years. And when we tried to intervene, they said, they thought that we are impinging on their authority, on their professionalism, on their certificates, on their training. But eventually they understood that we are telling them something right. So behaviors that undermine patients' culture of safety have to be reprimanded. This is one of my favorite things, which I always say wherever I speak. Act firmly when indicated. Word of caution, advice, reminder. Do not leave reckless, careless, negligent behaviors and practices without punishment and sanctions. Even we might speak that just culture, that culture, this culture, you will always find certain areas where these things are happening. So if people do repeatedly certain things, they have to be shown the door. You can't tolerate them because they will pollute the whole organization. They'll pollute their unit, they'll pollute the department, and they'll pollute the organization. And I think with this thing, I finish my presentation. And if I have some time left, I can go to the video if you allow me, or we can stop here.
I think it depends on how many questions we have. Thank you so much, Dr. Farook Mirza. We had quite a few very interesting comments, and I think everything was just turning about leadership. And so basically, what are we going to do if we have leadership that doesn't take this on board? I think that is the most concern. How do we change the culture of leadership? I mean, this wonderful example that you conveyed to us with the CEO, even standing in for it. How can we change in an organization that is not up to speed? How can we change that?
Yeah, actually, many organizations, what they have done and how they have addressed this issue, this is a very important issue. They develop a training model in quality and patient safety for the leaders. Leaders had no idea, no concept, because they were not trained. A leader in a hospital is, say, a senior gynecologist, senior surgeon, or a senior physician who took the position of a CEO or a medical director, but they were not trained in quality and patient safety. Sometimes they will tell you, I don't know about it. Come and educate me. So a training model, if you develop for them, I mean, with a lot of respect and regard and a little bit of creaming it up and other things, nice words, convince them that you also need to be trained. And that's the best way to take them. And board has to get involved. Board, all hospitals don't, many hospitals have the boards. Board training of the board is important. If you train the board, leadership will have no excuse than to accept the training. And who is going to train them? Quality and patient safety director, who is authorized, privileged, and licensed to do that. Yeah, that's important.
You also spoke about fear. Now, fear is one of the triggers not to speak up. Now, you gave us quite a few examples on why, but how can we, in terms of training, how can we train staff to overcome this fear, especially if you're a junior nurse, a junior physician? I think this kind of fear is all there, not only just in hospitals, but I think now we have a culture where nobody actually wants to speak up. How can we change this in terms, especially in patient safety?
It's a wonderful question, and I will try to handle it very carefully and very effectively. One of the best tools in modern patient safety culture development is storytelling. Storytelling is a very effective tool. You have to grab from the literature. What we used to do in our organization, we used to collect some stories from literature where patients were harmed. And harm through this broken system, harm through reckless behaviors. And we used to present those stories in a general staff meeting. And we used to break down those stories into the lessons learned and actions to be taken to avoid those things. And when you disseminate these stories every month in your, at least one story should be told every month, or each department should have a story in their department at the time of morning handover every week, one story. Storytelling is an effective tool. It's the best tool. And then all the thing. Tell them that if they report, they won't be reprimanded, they will be protected, and give them guarantees that they will be definitely, even at the general staff meeting, they will be brought to on the front, on the dais, and they will be rewarded and recognized. And some of them will be promoted. Some of them will be included in the quality council as champions. This will change the whole pattern. Really, storytelling is important. Very, very important. When you see harm happening, after all, we are humans. It does melt you somewhere. Harm which we could prevent. And I think there will be hardly anybody who won't come on board. Storytelling is the most effective thing.
Wonderful. Thank you so much for your speech. It has been very insightful, and I think we learn our lesson that we actually can take that back to our clinicians tomorrow. That's wonderful. Thank you so much. Do you have any other questions for Dr. Farook Mirza? please. Okay. Otherwise, thank you once again. I guess our participants will enjoy to get in contact with you and ask you some more questions later. Thank you.
And last of all, I would say one thing. Authority gradient is an enemy of patient safety culture. Authority gradient. Who can break the authority gradient in an organization is the senior leadership. Yeah. They can tell them that nobody is going to pinpoint you, reprimand you, or harm you, or hurt you. We are with you. The authority gradient has to be dismantled completely. The curve has to be flattened. If you see a curve which is flattened in terms of authority gradient, presume that your organization is safe. Otherwise, yes, it's not a safe organization. Thank you, Susanna. Yeah.
Thank you so much. Okay. Thank
Bye-bye.
you.
Have a nice day. Bye-bye. Thank you.
And you.